Welcome. Yep. We'll get there one day. Have a seat, everybody.
Evening, I should say.
Okay, thank you. Welcome again, everybody. We're going to go ahead and get started. I know we got a little gentleman coming in. But my name is Don. I'm one of the therapists here at Dynamic.
And I'm Kai.
Yeah. We're happy to have y'all here, and hopefully we'll teach y'all a little bit something with these shoulders and teach you some information about them. So, first thing I like to do is, I don't like to do a lot of talking, so I'm going to ask a few of y'all to kind of give me some information about you, what you're dealing with, how long you've been dealing with it, and before we get going, is it okay with everybody if I take my mask off and flow right here? We'll keep our distance, making sure we follow all the guidelines. How you doing, man?
How you doing?
I'm good. Can I have a seat and be your leg?
All right.
So, I recognize your face.
Yeah.
All right, so give me a little bit of history. What's going on?
Oh, I'm having a lot of trouble, like, washing my hair,
Yeah.
and, gel hands, parting it, putting on hands. Interior shoulder pain.
Interior.
Kai talked to me a little bit. I did discover that not sleeping on it helps a lot.
Okay, yeah, that's a big deal.
So, yeah, just that
Just that right side?
point right there. So, can you see if I can find out a little something about it?
Sure, sure.
See what's up.
All right. Yeah, we'll definitely touch on the sleeping positions.
I've been working on my knee for a while, so.
Yeah.
Makes progress.
Okay, and what's your name, man? Sorry.
Mike.
Mike. Okay. Sir?
My name's Terry, and over the last 20 years, I've had 5 shoulder surgeries
Oh, goodness.
and right replacement,
Okay.
titanium. And I'm here because the left one's going on, and I'm trying to prevent another replacement.
Okay. How's that right one doing?
Doing good,
Doing good.
doing good.
What's-
Y'all did the work on me, y'all did a good job.
Good to hear. Good to hear. What do you notice with that left shoulder? Is it the lifting? Is it just the
Well,
reaching?
I had to stop all sports activities when I developed no fishing or anything like that, because it was flaring up, I was getting flare-ups, and I didn't want to aggravate it to the point where I was causing it to need more surgery. So if I can, before you get this replacement, I came here before the replacement to strengthen the muscles.
In prepping surgery?
Yeah, and then I think they help, so.
For sure.
Probably going through all the exercises you were talking about, I just want to make sure that nothing loose going on.
Of course.
Together.
Yeah. Okay. Happy to have it. What you got going on here?
My name is Garrett. My right rotator cuff hurts. I play a lot of tennis, so anytime I go above here, it's not all the time. This happened about 3 months ago, and now once I got this email.
Okay. So first time, like you were serving when you first noticed
Yeah,
it?
mostly it hurts when I do this, like this motion.
Reach back.
Yeah, that's the main pain, and then above shoulder level.
Okay. So show of hands, who notices a pretty consistent problem with reaching back? Yeah. Yes.
What about with your head?
And like anything right above shoulder height. Yeah. Yeah. So we're gonna go over a few terms and go over the anatomy next, to kind of give you some idea about what's going on in the joints. But yeah, pretty much anytime you reach the point where you're going behind your back or over your head, everything's kind of cramming up in that space, and it kind of shuts the blood flow off. And especially when you have a malalignment or muscles just aren't firing when they should, then your shoulder blade kind of just tends to jack this arm up, and that's kind of where you feel all that localized pain. So next, Kai is going to go over some anatomy.
So all of y'all have little handouts to fill out, and so we're gonna answer this number 1. All right, so 1A is the rotator cuff is a group of 4 muscles that we're gonna talk about. And those muscles and joints help move the shoulder. So a lot of people hear rotator cuff and they think it's just one thing, but it is those 4 muscles. So I have a little picture here, but this is on your shoulder blade that should sit nice and snug on your rib cage. I'll have to go into everything, but the rotator cuff does help keep the humeral head, which is part of your arm bone, depressed into the socket. It helps keep it there nice and snug, kind of helps avoid impingement, which we'll talk about later. So if you can picture like a boat that has all these ropes, if they're all nice and taut and doing their job, the boat sits afloat and stays, no bumping, anything, no moving, stays where it's supposed to be. Now, if one of those is too loose, then you start having the rocking of the boat, hitting maybe on the side, and that's when you get like impingement. So all four of these should work together to keep the shoulder the way it should. And for 1B, the shoulder is a ball and socket. So one thing that we like to say is with the hip is also a ball and socket, but it's more concave. It sits a little bit better. It's more supportive. So it sits like this. There's not a whole lot of movement. So that's like your hip. But your shoulder is a little bit more flat, so it has more room to move. And that's what your rotator cuff muscles come into play. It keeps it here. When you have that loosening of the ropes, that's when it starts moving, bumping into stuff that's more unstable. So that's what the...
Excuse me, but I can't hear you.
You can't hear me? I'm sorry. What I was saying...
All right, I need to do that.
Okay.
Let me get settled.
No, you're fine. You can move wherever you need to
I
go.
think she could project a little bit.
Anyway, what part do you say about the hip again?
We just walked in, but I couldn't hear anything.
Oh, I got you. Well, what I was saying, to compare like a ball and socket joint, the other one you have is in your hip. It's a little bit more deeper. It supports the socket a little bit better. So that one, not many people have any issues with the hip as far as instability. But with the shoulder, there's a better chance because it's a little more shallow, like this saucer, so it sits like this. That's why these rotator cuff muscles, if they do their job appropriately, it should sit there. It should be more stable. There shouldn't be a lot of movement. So that's why that's so important. So that was B, ball and socket. And then C are these four areas work together during shoulder movement. So all four of these things can play into shoulder pain or causes. So the first one's in the neck. So we have a little demo. This is more of the lumbar spine, but to give you an idea, you have these nerves coming out of your neck. So sometimes that may be rotator cuff pain, but you can also have like radicular symptoms coming down the arm. So we have to rule out neck, shoulder, all this stuff to figure out where the pain's coming from. So some people, if you're having like sharp shooting pain, it may be coming from the neck, not necessarily the shoulder. So that's the first one. Then the second one is your collarbone. I think I'm missing my collar. Oh, here it is. I was like, where's my collarbone? So you have your collarbone, and what's pretty cool is this is the one bony prominence that attaches your shoulder to your, what we call your axial skeleton, so it's center. So if anything's going on with the collarbone, that can also cause some shoulder pain as well, okay? So the other one is the shoulder blade, which should sit snug, almost number 4, in your rib cage.
I'm gonna sit on the mat.
That's fine. Of course. So if your shoulder blade is having any issues, if it's winging away from the rib cage, if it's sitting off to the side, any of those issues can give you pain. And like Dawn was saying, if you don't have that space between what we call the acromion and the humeral head, you'll have what's that impingement. So if your scapula is sitting more forward, and we all kind of sit with rounded shoulders, the scapula will sit that way, and that puts you in a position for impingement. So there's all these things that tie into just the shoulder, okay? And with sometimes, I'm gonna go back to the collarbone, you can see that in the collarbone, there's a little bit of a rotational component. So all of you, that's what you guys to try. Just use the unaffected side. Just put your hand right on your sternum and kind of off to the side where your clavicle should sit, your collarbone. And if you take your arm and go straight up as high as you can feel a slight little rotation there.
It's very, very
It's
small.
very slight, but if it doesn't do that rotational component, that's going to also give you some shoulder pain. You may not be able to reach as high as you can because of that, okay? And I'm going to jump real quick. Did anyone get all those? Are you missing any?
Oh, we're just on
We're just on one.
one.
There's
I
3
don't have
parts.
the sheet you already.
You don't have the sheet? Oh, okay.
Yeah, right.
Oh, is that what we're
Yes,
doing?
ma'am.
Okay, so 1A, the rotator cuff is a group of 4 muscles. and joints that move, that's the second link, the shoulder. Okay? 1B is the shoulder is a ball and socket joint. Okay? And then 1C is the 4 areas that work together are the neck, the collarbone, shoulder blade, and rib cage. Got those?
What was the last thing you said?
Rib cage?
Thank you.
No, you're fine. Okay. And then some success stories. One of mine that I think is important. I like to educate my patients so they know what I'm doing, why I'm doing it, how I'm doing it, so they're informed. I'm not just taking their shoulders, moving it around, fixing it, and they have no idea. So I had a patient a while back. She did have a confirmed MRI rotator cuff tear, and she came in kind of upset, which I had treated her before, and she's very bubbly, and she was like, I don't see how you guys are gonna help me with my rotator cuff. I don't understand it. It's already torn. What are you gonna do? So I educated her, kind of like what I just taught you guys about the anatomy, explained to her how I was gonna treat it, what I can do to make her feel a bit better, how to accommodate things. And she started to kind of chirp a little bit. She's like, okay. So that's what I did, helped kind of strengthen those rotator cuff muscles, making sure all the ropes are taut, working the way they're supposed to be, making sure her posture was how it's supposed to be, how to accommodate the scapula where it should be so she can reach overhead. And sure enough, she's been doing really great and she didn't have to get the surgery. So I believe that education is very important to all of my patients, and that's one reason why I love doing what I'm doing.
And on that note, with the involvement of all these different locations, you know, that's one of my loves about the shoulders. It's very involved, it's very, like it's complex, but you know, you really get a good sense of how much help you can give some people, right? So my story I want to share with y'all, it was a younger lady, probably in her mid-30s, she's very active, gym-based routine, overhead squats, CrossFit, you name it. Came to me, she hasn't been working out for a month, and she was complaining about all this neck tightness. Not so much pain, maybe a little pain here and there, but it was just a lot of tightness. All in all, 4 weeks later, we kind of calm things down, we get everything right, she's not complaining about any neck pain. I follow up with her a month later, so 2 months from her initial injury. Yeah, and she tells me, you know, I didn't really tell you about this, but I was having some shoulder pain, especially just doing my clean and jerks, and now it just went away. Like she never mentioned it to me, but you know, it was still bothering her. So on my follow-up, I learned that, oh, maybe all that stuff that was messing up with her shoulder stemmed from the neck. So that is, you know, one of our jobs is to do a very involved, thorough assessment to really understand if it's truly the shoulder, if it's coming from the neck, if it's more of a shoulder blade, mid-thoracic issue, because our bodies are very, very involved, very complex. Like to Kai's point, we have those radicular symptoms that stem from the neck. We also have referred pain. So pretty commonly with the supraspinatus, one of the most commonly involved rotator cuff muscles, you typically have this localized pain response that you know, you can't quite shake. It's like, not your bicep, your elbow's fine, I can curl my arm, I can grip, but it's just anytime you go here, it's not my shoulder, it's more my arm. So that's pretty commonly known as a referred pattern from one of the rotator cuff muscles. Okay. So yes, so going into some imaging stuff. I have a few common diagnoses right here. So osteoarthritis, bone spurs, impingement, rotator cuff tears, or rotator cuff sprains. I want to ask you guys a question. So they surveyed 100 people in each of these age groups, so 50-year-old age groups. What percentage of the 100 people had a positive MRI finding? Had a positive MRI finding of one of these 4 diagnoses?
A large number.
A large number. Pretty good. We're going to call it 80%. So 80%. Okay, so 60-year-olds, we'll go 10 years older. What percentage of that population had a positive MRI finding?
What's the age?
60.
60.
No, just 60-year-olds.
60-year-olds. 100 60-year-olds.
What was the first age you were?
50.
Oh.
So 50, 80%.
Let's give it a 90.
Give it a 90.
Okay.
Right on the money. So 90% of 100 60-year-olds had a positive MRI finding. All right, let's go one more. 80-year-olds. They had a 99% finding. Okay, so of 150-year-olds, 80% of them had a finding. 60-year-olds, 90% of them had something going on in the MRI. What do all these people have in common? They didn't have any pain. They were functional, they didn't have any issues. So, all that to say, you are not your image. You are not your MRI. The MRIs are typically taken stationary, right? Are you moving during an image? No, not really. And so us as the movement experts would really have to take that into consideration and try and figure out, well, what mechanical abnormality are we dealing with this shoulder? Not to unload on MRIs or images, they're great, they're fantastic, especially for ruling out those nasty things that we just can't help. So this is all to say, consider that you are not your MRI. And that is very important to try and figure out if it's coming from the neck, if it's coming from the shoulder blade, the ribs, the mid-back, and all that to say, you have to not hone in on one thing. There are other things that could be playing a role in what's going on in your shoulder. Okay. All right. So another thing about injections and medications, they are fantastic for altering that pain, but ultimately they're not going to fix the underlying problem, the underlying condition. They might. I've had multiple patients, I'm sure Kai has as well. They get an injection, they feel fantastic. They don't need therapy anymore. Like, I understand that's awesome. I'm glad you're feeling better. But why did you need that injection in the first place? Like, that is what I'm more concerned about. I'm so ecstatic you're feeling great, but let's nip this in the bud and make sure it stays that way once that injection wears off. So I'm a big proponent for injections in PT, and especially injections in general, because they help us calm the pain and inflammation down, and they allow us to kind of get moving. Yes, sir.
Do you do injections?
No, sir. No, sir. We refer out for those type of things, especially for imaging, imaging injections, pain medications. We leave those to the doctors. Yeah. Anything you want to add to the injections? Or?
With the injections, I feel like they're good for certain reasons, and sometimes I feel like they're not that great. So I know after you get like repetitive injections, they can actually cause more harm than good, because it kind of aggravates the cartilage in the tissue, and kind of can aggravate like the tendons, the muscles, the cartilage, everything. So if you have, like, let's say you come in, we're working on your shoulder, and we just can't get past this hump. You're always having this pain with this movement. If we can't get that to go away, then we're like, okay, you know what, let's get an injection, let's get over that pain so we can keep going. That's when I would say an injection is good. But if you are having pain, like we said, you get the injection, you're like, you know what, I feel great. Let's figure out the source of it, because if we don't figure out the source of it, it's gonna come back. It can be days from now, weeks from now, months from now, but you're gonna come back, the pain's gonna come back. So pain meds, always take them, depending on what the issue is, take them if you need to. I'm one of those, I don't really like to take medication, but I will if I have to. The injections can be good or bad, not too many, not too often, and sometimes doctors will cut you off. Like after so many, they know if I give her too many, it's gonna cause damage. So with PT, we want to find the source of the problem. We want to make sure it goes away or accommodates you in any way that we can get you better or back to what you were doing before you came to us.
All right. Now, I'm gonna have everyone move a little bit, get the blood flowing. I want to show y'all just a little hands-on trick. I'm gonna take a member from the audience, but before I do that, I want to see how y'all move. So, the problematic side, whether it's right or left, or if it's both, I want you to pick the more involved side. And I want you to just lift that arm straight up, if you can. Kind of observe, see where we are. Okay. Pretty good. Pretty good.
Staying up.
Oh,
All right, bring it back down. Love it, love it. Okay, let me see that other side. We'll try and get a comparison. Okay, there we go. Gosh, that look good. Gosh. Okay, go relax. Huh?
You saw the last.
All right, one last thing. I want you to turn your head to the right for me. Check that, check that. All right, now let's go to the left. All right, relax.
I think the gentleman in this navy shirt in the middle.
Maybe sure. All right, come on up, everybody. Yeah, sure.
Oh, no. We just needed a little chair.
You do get to say it. All right. I'm easy for me. Not to put you on the spot, right?
That's all right.
All right.
Yeah, you're welcome.
All right. side are we dealing with, sir? That right side, okay. All right, go ahead and lift that left arm up for me. Over. All right, what do you feel about right there?
Pain like right
And right there, okay, can't go right.
I can't, go further.
Can't go further, let me see this one for me. Mark improvement there, no issues there, huh?
No.
So I'm gonna have you do this, sit up nice and tall. So slide, lean forward for me, slide it up back, good, very good. And all I'm gonna do. Any issues with your neck?
No.
No. Over here. All I'm gonna have you do is lean to your right with your neck. There. And relax. Back. Perfect. Good, one more. Okay. Any issues here? With me pushing
A little bit.
a little bit, where my finger is?
Yeah.
Can I adjust my grip here? All right, we'll go again. To your right. Perfect. Push. Good. Okay, let's go two more. Perfect. And one more. Okay. All right, sir. So I'm gonna have you lift your arm up again for me. Push. Okay. How's that feel?
Better.
Better? What's better about it?
It just doesn't feel as tight.
Doesn't feel as tight. Okay, fantastic. Wanna relax there? You okay right here?
Mm.
We'll do it one more time. Straight up. Push. Good. Still a little tight there, huh?
Yeah.
Okay.
A little bit of pain.
Okay. So it was a marginal little improvement from about right here to about right here. But the biggest thing is, there was a subjective improvement, right? It felt a little better. So all that to say, you know, all I really did was move his first rib right here. So this is what I want y'all to do. If you take your finger, find that clavicle, and I want you to go not quite to that big muscle belly at the top, but right under it. And I want you to give just a little push. It's gonna feel a little tender, okay? And that's what we call the first rib. That first rib doesn't attach to anything, it's really involved with breathing, and it attaches to some muscles up into your neck. But as you can imagine, it can easily get tight and jam up that shoulder. Because if that first rib doesn't elevate, it's gonna get locked down, and it's gonna cause a lot of just tension in that shoulder, okay? So all I did with my friend here was just kind of push that first rib down, and ultimately, that might be one aspect of his treatment plan we might consider continuing with. And on top of that, you know, we definitely addressed his mid-back, his shoulder blades, and some of this tightness I feel up into the neck. Okay. Okay, thank you so much.
Done?
Yes, sir. Any questions about that there? Any questions about anything so far? No? Yes, sir.
Do you find that most of your focus is pre-surgery or post?
A lot of the cases are, it's kind of hard to put a percentage on it, but a lot of the cases are, I'm hurting, I need to get some help here. Fortunately, it's with the inclusion of something called, we have direct access in Louisiana, it allows us to treat patients immediately, right? They don't have to wait for a doctor's visit, or they don't have to get a referral. So it allows people to come to us a little sooner, we can kind of get our hands on them and kind of figure out what's going on. So, you know, ideally, I like to see everyone deserves an assessment prior to surgery, right? So, you know, I am treating a few people right now that are pre-surgery, like, yeah, you need surgery, it's been 10, 20, 30 years, doctor says it's messed up, and, you know, we've treated them for a certain time, and things just aren't moving along. So, you know, that's a very good question.
Do you find that you get post-surgery follow-ups?
Yes.
with Physical therapy?
Yes, yes, absolutely. Especially with rotator cuff repairs, that is a must. Because pretty common finding, let's just say, you know, something happens, PT doesn't happen, life circumstances, busy, you know, your doctor said you don't need it. A pretty common thing is frozen shoulder, and that's just, you know, post-surgical, those tissues need to move. They need to move. They're gonna get locked up so quick. So post-surgical is imperative you move, right? Then you have restrictions, and you have doctor's orders and protocols you gotta respect, and not push it too much.
Yes, ma'am.
I have a question.
Yes, please.
Let's presume you have a positive MRI.
Yes.
And your doc says, well, I think we need to do the surgery, and your At that age, and you're kind of like, look, if I can learn to live with this and I can get some PT,
Of course.
then I'd like to do away with the idea of surgery right now.
Right.
That to me would be a focus I would come to you for.
Of course,
you know,
yeah.
And ask you for a role. That's also a goal that you could have, if you can avoid the surgery.
That is a big deal,
And
yes.
for us, I like to focus on your decision. I always respect your decision. And I do have a patient right now, she has 2 rotator cuff muscles that are torn. She never got them repaired, all she has is the pain. And she's like, she's a candidate for surgery, she just doesn't want it. She's like, I'll live with it, I'll do what I need to do, just get me better. And I'm totally fine with that. Teach her how to do accommodations, get her as strong as I can, get her as much motion as I can. For her, hers was what we like to call like adaptive shortening. So she's been protecting her arms here for so long that all the muscles right here are all tight. So once I've gotten those loose, she literally went from this to here. So that was nice. So she didn't have a full thickness. So what we call full thickness is like you have like a little chicken wing. You can't really raise it. So you'll hear full thickness, partial thickness. Partial is, okay, I can move it, but it hurts here. That's like a partial. But full thickness, because people will hear, well, I got a full tear, but I can do this. That's not a full tear. You would know if it was a full tear. So yes, I want to get you to where you want to be. If I can get you to where you don't need surgery, that's the goal. For some, which I'll go into here in a minute, there's some people who get therapy and they have to have it, and that's okay. But I have a gentleman right now who I was saying before his surgery, I got him his full strength, I have his full range of motion, and he's coming in as soon as his surgery is done. But that was his choice. He had the option, and he's like, you know, I told him, I said, you don't have to have it, it's always up to you. But if you get the surgery, and this was better for him, I said, if you get the surgery, you'll come and see us for so many weeks, get you back to where you're going, and you won't have any pain anymore. And he was fine with it.
It's
So
just such a long rehab.
it's long, but it's worth it in the end if you have to have it and you opt to have it. Because if you don't come in for therapy, you're gonna have at risk
So
for
you got to come in for therapy.
You have to come in. But no, I always try to do what my patients wanna do and abide by that, and I give them my honest opinion. If I feel like they truly need it, I'll tell them, but it's always your option. But I'll do whatever I need to do for you. Yes, ma'am.
I'm a longtime patient here, was done every calendar year, I think, since 2015. Different issues. 2 years ago, I tore this right rotator cuff. I'm left-handed. This one was repaired in 2004. And, this one was torn 2 years ago. And my orthopedist didn't recommend surgery. I mean, it's a good tear, but it's, I think it was my age. I'm mid-70s now, so 2 years ago, it was early 70s. This got better, because I did the home therapy when I left here, January, I think, of this year. And it got better, but I fell on October 15th, and I re-injured this whole side and my lower back. But in the meantime, I have a really bad neck. I mean, when I say a really bad neck, I mean, Steve has the MRI of my neck that Chip Davis did. And, that was like in 2018, 20-something. But now this arm hurts worse. I'm left-handed. This arm hurts worse and this one's definitely a rotator cuff there. I mean, I can see it.
Yeah, I saw you over there.
But this one, I don't know if it's my neck or I've torn the rotator cuff again. I was talking to Steve today. I was in here today as a patient. And, I don't know whether it's my neck, which has been messed up for lots of years since childhood, or it's, as you were describing, what could be neck and what could be rotator cuff. But sometimes I think it's rotator cuff, and then sometimes I think it's the neck. Because my original left shoulder problem back when I was in my 40s was because of my neck, not from the rotator cuff. So my surgeon said, I don't know if it's age or what, but he said, no, let's do physical therapy instead of first. And that was 2 years ago, or a year ago, January.
So were you asking if it was better for you to come here first?
Well, I mean, right now, Abby back here and Steve and Scott are working on strength and balance first.
Mm-hmm.
Then we're gonna address these issues, but I don't know if I can put up with the pain. You just reminded me, when I first got this rotator cuff tear, he did give me an injection. I have not seen an orthopedist about this, because I went to see my PCP because I had an appointment with him already, and he sent me to PT. But, this arm is bothering me so much, I have trouble sleeping at night, and I'm wondering if I should get an injection. I mean, I'm an anti-med person too, but I'm wondering if I should get an injection, just so I can get through all this strength and balance stuff till I get to this point.
It all depends. If you're with Scott and Abby, I mean, they're gonna tell you. If they've worked with you for so long, and I know you just started, if it gets to a point to where you can't make any progress, they'll refer you to an injection or whatever you may need.
Yeah, okay.
And we also have a laser here that we'll mention at the end.
Yeah, Steve and I talked about that today.
Any other questions? Okay. I'm gonna get into a little pie graph. So I graduated in April, but I did do the presentation with Michelle, so I can try to explain what she said. So back about 20 years ago, therapy wasn't where it was today. It wasn't as hands-on. We didn't have all the research and technology back then. So when people came to PT about 20 years ago or so, this is what the progress kind of looked like. So about 50% of people were like, I'm not too happy with my results. I'll live with it, it's fine. With some, they also, well, most of them said they. For some, about 25%, there was no change, no difference. They just had their pain, they also lived with it. And there was this 25 that were really happy with their results. But the only difference between 20 years ago, I'm not gonna say how old I was 20 years ago, and now, so now what I was saying for, like for you and for my patient, now we're more hands-on. I'm very hands-on with all my patients. I like to do manual first. I have always a little warm-up, and 2 of my patients can vouch for it because I see both of you out here. They know I do manual at least like a good 20, maybe 30 minutes of it. So that's one big change since then. But now there's only 10% where they need surgery, they need injections or whatever, to where we do everything we can to get you better. But like my gentleman who has a slap lesion, he knew he had a slap lesion, he had an MRI for it. I tried to get him as best as I could, but he still had the pain. But that's the one big difference, is that we're very hands-on now. There's more schooling, we have the doctorate program now, and back then they had like the masters, and then we have open access. So for them, for 20 years ago and now, there's a lot more progress. So doctors refer to us first now for pre-surgery and post. So I do remember learning about 20 years ago, doctors didn't send their patients to us after surgery. And then they would come in 2 months later like, oh my God, I'm so stiff, I can't move it, I don't know what to do, because they would keep them in this sling and say, you know what, just rest it, let everything heal, you'll be fine. But then they found out that the sooner you start moving, the better. So that's a big difference between those two. But yeah, and there's, not all clinics are the same. We do get lucky, or like for us, because we have a lot of new hires like us, we're kind of fresh out. I'm the freshest, really. Out of everybody.
Fresh can be, yeah.
Literally April. But yeah, they do teach us a lot more hands-on. We have multiple classes that teach manual. Everything's much more thorough. So we're always learning. Physical therapy in general is always growing. We're always learning something. I'm always researching when I go home. So that's the biggest difference. And doctors are actually more aware of what we do now versus back then they weren't as aware of what we do and how much we can help. And I think that's it. And why we decided to be specialists. Little more backstories. I've always loved helping people. I thought I was gonna be a pediatrician and then changed my mind in college. I loved sitting with my patients, getting to know them, because compared to the doctors, they see you for 15, 20 minutes, versus I get to see you multiple times a week and get to know you and your dogs and your kids and what you do on the holidays. So I've always loved that, and because it's so hands-on, I get to learn new stuff every day. New patients come in with new problems, and I love to try to solve them, and I love to try to get you guys better, because there's nothing more rewarding than those that come in. Actually, I had a gentleman that came in who fell, was in a wheelchair. When I saw him, he needed help to get out of the wheelchair. And I just discharged him this week, and he was so excited. We were walking around the building, and he was holding up his cane, and he's like, I don't even need this anymore. So like moments like that are so rewarding, and why I really do love my job.
Man, hard to follow that.
Oh, I'm sorry.
No. So, I'm not so fresh, I've been out about 5 years, so I've treated a multitude of shoulders, body parts, you name it. Yeah, it's just so rewarding to kind of just see little glimmers of hope and little changes every now and again. That's kind of why I keep coming back.
That's what CEU's all about.
Oh, yeah, of course.
Yeah.
So yeah, moving number 2,
Oh.
I think your worksheets have, who is Michelle Sierra?
Yeah.
On there? Yeah, so she's one of the owners of this place. She's not here tonight, so to see you all, but, yeah, we piggyback off each other in this place, and we do a lot of co-treating. And we just have a lot of good brains outside of this office. So let's move, number 3, back to normal, first steps. Here's a big thing that I did want to touch on. If your shoulder pain is reproducible, then it is reducible.
What was that second word? I got to reproduce.
Reducible.
So if it's reproducible,
Got it.
Reproduce.
then your pain is reducible. So, which means if you come in for an eval and I can figure out or demonstrate what causes your pain. So if you're like, oh, well, I have pain right here. And if I go in and I move it and you're like, that's it, that's my pain. If I can cause your pain, then I can help reduce your pain. So some of the red flags that we'll talk about, if you ever, I'm sorry?
I was just coughing and saying it's not.
Oh, okay. So one of the red flags with shoulder pain is if you come in and I can't reproduce your pain, or your pain never changes, doesn't matter how you sleep, doesn't matter anything like that, that's when it's a red flag. That's the one time where we refer you out to see the doctor, because then something else underlying is happening. We like to try to reproduce it, figure out what it is, get it better. If we can't figure out what it is, then that's when we refer you to the doctor. Let me see. So that was 3. Hold on a second. I figured what 3 looks like. So on your worksheet, at B, it says, in the past 30 days, the worst pain I've had was, and you'll write whatever number out of 10. So 3 out of 10, and I tell my patients, a 10 out of 10 is I'm being attacked by bees, I need to go to the ER. Because some people will say, I'm 10 out of 10 pain. It's like,
No,
no,
you're still standing
you have
there,
a smile
you
on
don't
your face.
tears.
There's no tears, so that's not a 10. So just put what your number is out of 10. And then C is I have pain when, and then you guys just circle whatever is more specific to you, what causes your pain. Okay, so one of the things that I actually learned from Michelle is, okay, I know I'm a belly sleeper, which is probably the worst thing for my neck, but if anyone's like a back sleeper or a side sleeper and they're having that shoulder pain, if it's one shoulder, you can take the pillow and put it right underneath your shoulder. So the goal is to have you rest in what we call open pack position. And like Dawn said, if your shoulder's all jammed up and cranked up and you can't get that blood flow in, that's when you wake up with shoulder pain. And was it you that said when you're sleeping you're having pain? Which one? So were you side sleeper? We talked about this. Okay. So when you're laying on your side, you're closing up the joint, there's no blood flow going. The shoulder puts you in that position to where the joint sits open. There should be a space between the acromion, your rotator cuff muscles, and your humeral head. That's how you get all that blood flow while you're sleeping. Your body can like reset itself, cleanse everything. That way you actually have a chance to wake up without shoulder pain. And if it's both, I'm gonna come right back to you. If it's both, you can put 2 pillows, but you want a little bit in the back to keep your shoulder from coming back. Because I know my personal issue, my little tendon right here, I tend to let my arm rest back here and you put that tendon on a stretch. So you want to take the back of the pillow, kind of prop it up and lay back. Or if you lay on your side, just lay on your side. And you guys can try that at home and see how you feel.
Are you saying that we shouldn't lay on our sides when we sleep?
Not if it's the side that's more painful, I wouldn't. I have had patients that I've told them to try this and they're like, my pillow ends up on the floor. Try it anyway, keep trying it. But no, if you're comfortable laying on your side, let's say it's your right shoulder pain, don't lay on the right shoulder. Lay on that side, prop this underneath, see if you can stay that way, or like, what was your name?
Emmy?
Emmy. You're Miss Emmy.
Yeah, I'm infamous.
I like that. Like for her, she can prop both, lay on her back, and just have a little space
It's
back
a good
here.
thing I'm a back sleeper.
Well, there you go, it's perfect, so that's your homework, Miss Emmy, so when you come back, I'm gonna ask if you do it.
So you say put the pillow underneath your body or put
No,
it
just
lay
put
on
it
the
right under your
opposite side
arm.
with the pillow on top of your body?
No, just put the pillow under your arm like this, and you see this little back space?
And you're gonna lay on that arm or you gonna add that arm up?
No, you would lay on the opposite side. So if
Oh,
it's under
okay.
my left arm, I lay on my right side. Or if I wanna lay on my back, put it underneath the arm and have this little bit back here so you can lay on it that way.
Well, I sleep on my back, and like last night, this pain was so bad, just lying down, and so I had to ice it just to go to sleep. That and attend over to Norfolk, but I iced it to go to sleep. Because the pain, just lying down, I'm better sitting up or standing up for pain than lying down. This one has a, we for sure has a torn rotator cuff. This one may be re-torn or something else. But
Well, that's your homework for the
this one
night.
doesn't hurt as much, doesn't hurt as much as this one.
Well, Abby's gonna tell me if you did it or not.
And to that,
I'll be
There
back
you go.
Friday, I guess, yeah.
Okay.
Yeah, Friday.
We'll make
is
sure she
11
is.
a.m. Steve, I think, but that would be good.
and to that point, ice and heating, you know, those that have been dealing with months, years of this, it's really comfort. Like, being a therapist, I'm not really picky with, whether you put ice or heat, it's whatever's comfortable to you. If there's an acute injury, like tonight, you don't push, it's, ooh, man, kind of strained it, kind of ramps up a little bit, then I suggest ice, just to kind of calm the inflammation down.
When would you see, I'm sorry.
Yes.
Oh,
Over
the
the
ice.
heat, the heat ice debate is more for comfort. But if you just had like a little exacerbation, like something flared up.
Yeah, I'm
hey,
a nice person, so
and then everyone has their choice. Like some people don't like heat, some people don't like ice, and I respect that. That's just whatever makes it feel better. Right. Okay. So I think the next one, number 5. No, number 4. I'm sorry. The biggest mistake shoulder pain sufferers make. What do y'all say? Ignore it. That's it. Ignore it. And so, you know, there's a lot of things going on in this world, right? Could be an earthquake. Who knows what's gonna happen next? And so there's a lot going on. You know, it's really a priority, and we're here to help you. We wanna kind of. It's just like Kai was saying, we're master puzzlers. We love trying to figure these things out. And you know, our number one goal is to get y'all feeling better. So we're here tonight to learn a little bit of something. I hope y'all did. And the next question, number 5. 3 things you can do about your shoulder pain right now. Number A, ignore it. All right. Number 2, number B, I'm sorry, alter it. That's more along the lines with the injections, with the pain medicine, the heat ice combo, maybe with a 10 unit. Number C is handle it. Okay. And hopefully everyone's here tonight to kind of get a jump start on that handling portion.
Everybody get those? Alright. Alright, so number 6 is the top 3 common causes of shoulder pain. So A, we talked about neck. So A is problems in the neck. That's when you would get the radicular pain, symptoms coming like beyond the elbow, stuff like that, sharpshooting pain. B is impingement. So you usually get impingement before the rotator cuff tear. That's whenever the humeral head's pressing against the tendons, banging against your acromion here, causing all the pain. If you do that too much, you can cause bone spurs, that's not on here, or the tear, okay? And then C is poor posture. So I'm gonna show you guys something. Whatever is your unaffected side, this is the one time you can have poor posture and it's okay at a PT clinic, okay? So I want you guys all to slouch, horrible posture, okay? Unaffected side, can you put it up as high as you can? Okay, it may be a little uncomfortable, you may be able to get it up there, but it's like, something's kind of stopping me, right? Okay. So now, chest up, roll the shoulders back, good posture, now we'll let that arm go up. And you see how easy that arm goes up. So what I was saying before, when I was talking about the anatomy, if that scapula is rolled forward, and you're gonna raise your arm up, you can't, because that acromion is in the way. okay? So that's one of the causes for what B is for impingement. So that's one key thing that we all do with shoulder pain, doesn't matter what it is. All of us focus on posture,
It's a big
because
one.
it is a big one.
Big one. And you know, I'm not of the opinion that everyone needs to walk around like this, right? Because that's very unrealistic. But it has to be on your mind. It has to be something in your treatment plan to maybe put a little sticky note here and there. Every time you see that little green and blue sticky note, you're like, oh, okay, shoulders back. You know, just kind of get out of that funk, out of that one position that could be contributing to that pain and to that inflammation in your shoulder. Okay. So yeah, that's on eval. Typically we go over sleeping postures, general posture, just like as you're driving, as you're sitting, as you're standing.
I just want to kind of add something.
Yes.
That I thought we might even address tonight, is the fact that I was told by either an orthopedist or a physical therapist that women especially, and people over 40, let's say, women especially, if they do not work out their upper body as an exercise, if you do not keep your upper body strength forever, you know, if you stop working out, you do things like, or stop playing sports like I did, you're probably likely going to tear a rotator cuff. You know, at 40 and 50 and 60 and on, you know, it's like, because you're gonna do something stupid and tear your rotator cuff, and you don't have, you just don't have, those four muscles are weakened, because
Right.
they haven't been used.
Right. So yeah, you know, we have, kind of coming back to this percentage here, you have normal age-related changes to your shoulder.
To male and female.
Yes.
To male and female. Yeah, yeah. And to your point, yes, the older you are, the more likely a potential injury could happen. Now, could that injury be related to your symptoms? You know, I don't know, potentially, right? So it's important to kind of
There's probably
distinguish.
not too many 20-year-olds in here.
We're back there. So yeah, that's why it's important. Everyone deserves a mechanical assessment. Everyone deserves to be given the education to really fully dive into, okay, this is what I'm thinking. This is kind of the symptoms are kind of following this certain pattern. And you know, that's kind of where we sit and how we can help you.
Number 7 on your worksheet. So what does successful, non-invasive, natural treatment look like? So that's where we come in. Number 7. So you have hands-on, which is what we do, hands-on PT to move the shoulder and surrounding joints. So that's A. For B, you have strengthening exercises to retain muscle memory. So that's kind of cueing like, oh, make sure my shoulders are back and down before I reach overhead if you're trying to avoid surgery, stuff like that, posture. And C is pain and inflammation relieving modalities. So that's the heat, the ice, TENS, our laser, anything like that we can help decrease your pain while we work on your hands-on and work on your strengthening, so we can get you back to
And
a
that's where
shoulder.
kinesio taping and stuff.
Yeah.
goes into.
Yes, ma'am. All right, so tonight, you guys have 3 choices. So who wants to ignore their pain? You came here for a reason, so I'm assuming you don't want to ignore it. All right, so 2 is alter it with the injections, the pain medication, stuff like that. So that's your all's choice for tonight. Or you can deal with it and handle it right now. So if everyone wants to deal with it and handle it, we have Sherry and Candace up front who will be putting evals or 3 screens for everyone that we can fit on the schedule today or for the rest of the week. Those who have like 5 to 10 out of pain or more, we would love to see you guys first. Not that we don't want to see everybody, but let's try to address the people who are more severe, who really need PT right now. We'll try to get you scheduled as soon as we can. But obviously, we want to see everyone. I do believe they have some spots open on all of our schedules right now to fit as many as we can. I think, let me see. Yeah, they're ready, they're looking. All right, so if you guys have any questions, you're more than welcome to stay and ask us some questions, or we're gonna stay around and look around. You're welcome.
Well, thank you all for coming out tonight. Please stay for questions. I'll be here. Anything we didn't address, any underlying questions you got?
More important, you suggest.
I didn't ask this question, I was insurance question, you may not know the answer. But you have a one name, a one second.
Post-surgery PT.
I know Chase. I really love Chase. I love him too. And
But we're a long time friends.
if you see him, tell him. Gotcha.
So Cindy is my sister, she's the one who, Barbara.
Well, hello, Cindy.
She's got, she's in here by tomorrow.